Okay, we are recording. Hello and welcome everybody to our August 3rd virtual CQM series training. Today we're going to be talking about CQM performance measurement. We're breaking CQM performance measurement into two parts. So this time we're going to be focused on care markers on the HIV Care Continuum, and next time we'll talk about the qualitative piece, more from surveys and focus groups and all of that. So I'm Michael Hager. I am one of the consultants who has been contracted by Dallas County Health and Human Services to do CQM capacity building and consulting services. And my colleague Jamie is with me today. And I'm really excited to turn it over to Oscar to introduce the session.
Thank you very much, Michael. I'm glad that we have participation of basically every of the 12 subrecipients that we have, and I hope you get the fun out of this training, because this training is very interactive and those 2 hours fly like a very interesting bird. And at this time, we have a reminder. You have these two links, the training series YouTube. All of this material will be in YouTube channel that you have access to. And in the glass cube, you will have the materials of the previous session that recorded on that glass cube. I will encourage you to join glass cube, and the CQI will send you a welcome link for you to come in and check our site, check our material, and go back and revisit. If you have someone new on CQM, that's the best way to train. Someone is new, joining CQM, and wants to know what is the requirement, how the whole CQM based on the HRSA requirements actually should be working on. So welcome again, and I'll pass the voice to Regina. Regina?
Right, thank you, Oscar. So good morning, everyone. I am going to share with you about the helpful hints on how to use the Zoom meeting. You can press escape to exit the full screen. If you hover over the top to change your view options, you can also place yourself on mute until you're ready to pose a question. There's also the chat feature. So, and it looks like everybody is saying good morning already, and if they have to get off. And so thank you for letting us know that. And of course, this meeting will be recorded and available, as Oscar mentioned, for sharing after the meeting. So now I'm passing it on to Angie. Oh, and there, oh, there, and there's a point button. There's the mute button. And let's see, who's going to show us where the chat button or the chat feature. Let's see. Oh, there's Angie showing us where everything is. Stop video. Let's see. And then there's Jamie showing us where the chat feature is. So, and do we have one more? Yeah, the exit screen, full screen. There's Oscar showing us where those are. So, and now, and there's the team waving hi. Hello. And then am I just switching it over to, oh, and also I will be doing the name, we'll be doing the agency name tagging for you as well. And so if you would like, this allows us to assign you to your breakout sessions. If you want to add any pronouns, we're giving you the flexibility to do that as well. And if you get disconnected and rejoin without your agency name, we will add it back for you. And now I'm passing it on to Angie.
Do you want me to go ahead and take this one?
Oh, I'm sorry. Maybe I skipped over. Oh, I apologize.
No problem.
I apologize for that. Also, you're going to be tagged, and when you'll be asked to join into your breakout room, this screen will pop up for you to join in. For those of you who weren't able to make it to our previous sessions and not familiar with the Zoom process, you'll receive that, and within a matter of minutes, you'll be zipped into your breakout room. And then once that time is up for you to participate in your breakout room, you'll be brought back into the session. It will ask you to actually go back in, but even if you don't click on it, it'll suck you back into the main room. All right. And I think that's it for me this time, correct?
That's right.
Good morning. Let's go over our learning objectives. So we're hoping by the end of today's session that you'll be able to name the stages of the HIV Care Continuum, explain how services provided by your subrecipient agency affect the HIV Care Continuum, describe the concept of care markers and how they relate to the HIV Care Continuum, link your subrecipient agency's ongoing data maintenance activities to the AA's 2019 QI project on performance measurement, complete a comparative analysis for your subrecipient organization's data variance between what is shown in your home data system and ARIES. Next slide, please. I believe if you're registered today, you received, right before the session began, you received an email from Michael and the team about the toolkit. And so in that toolkit, you should see the document for the CDC's HIV Care Continuum and definitions, draft care marker definitions, and EMA HSDA data variance worksheet. Okay, Oscar, it's up to you.
Thank you. Thank you. And it's time to check ourselves. The next polling, Michael, pop it up. It's a care continuum questions. It's a very simple thing. How familiar are you with the concept of HIV Care Continuum? Remember that 2010, someone come up with that? The Care Continuum, and if you have a clear understanding of the service the agency provide, how your agency actually play into the care continuum. That's the next. We want to have a sense of how familiar you are, and if you feel, how do you feel that you can contribute with the care continuum, with the cascade, Gardner cascade.
All right, we have 12 of 26 in. Let's see if we can get up to at least 16. So I'm waiting for a couple more votes. All right, one more, I'm at 15. All right, great. Let's go ahead and share the results here. Go ahead, Oscar.
All right, we have the familiarity of the Gardner cascade or the care continuum in 75% of the group. But I will encourage you, please get into the polling and give us opinion about it, because if it's 16 out of 26, it's still a little low in voting and participation on that. I will encourage you to do it. And some of them have heard of it, like 19%. And we have some newbies on this one. So good news for that, because this is the basic. This is like the baseline for everybody where you should start on the care continuum, and you will have a very good grasp on what is the care continuum and how do you contribute. It's the set question that tell us, like, for all services that you provide, 56% feels very connected to the care continuum, contributing into the care continuum. Some of you feel like somehow some services, but not all of them. And someone said, like, no idea. It's great to have that opinion, so we know what we have in the audience. And we had a kind of idea on, we had different levels of understanding on CQM on this group. So, but that's great, because I mean, we can establish the baseline. And for those who see that they contribute little in the care continuum, you might have a surprise at the end of the series, because you do have a huge contribution on the care continuum. Every single one HIV provider have a contribution in the cascade. Michael?
Great, thanks so much for that, Oscar. And thanks for participating. I've noticed that we have a couple of folks who have dialed in, so I'm hopeful that you've been able to receive the toolkit. I did get a note from someone that they didn't receive the toolkit, and it came from my Gmail address. So just check your junk mail. put a note in the chat. If you didn't get it, we're happy to send it again. It's no problem. There was another note that I had wanted to make about this. Oh yeah. So if you have dialed in and you're not able to see the slides, and all of a sudden you're trying to talk but you feel like you're muted, you can press *6 on your phone. *6 and #6 will mute and unmute your phone. We ask that we keep our lines muted until we're presenting and sharing back, though, you know, from our own perspectives, just so that we avoid any unwanted interruptions and fabulous on-hold music that you all have. All right. That being said, let's dive into the main dish for today. We're talking about care markers. But first, we want to go ahead and respect the fact that some folks aren't fully familiar with the concept. So we're going to, you know, ease into the water. And someone here. So the Care Continuum was first created by Ed Gardner at, in Colorado, actually in Denver, in 2011 as a way to describe the daisy chain of processes and outcomes that are involved in HIV care and treatment. And the issue was that in terms of thinking about the framework of how all of our activities in treatment kind of lend themselves to the endpoint outcome of viral suppression, we wanted to have something to look at and talk about. And it was so novel in its approach and its design that folks really picked it up and ran with it, which is why so many of you are so familiar roughly 10 years later. It was formalized by Irene Hall of the CDC in 2012. The term cascade versus care continuum, you know, we started seeing, you know, different use of terms, but if you see the term cascade or the term care continuum, it's basically the same thing. The Care Continuum was organized almost immediately into national activities like the In Care campaign that lasted from 2011 to 2014, Fast Track Cities, which is a project of IAPAC that links together the concept of 90-90-90. Then we have the concept of 90-90-90, which is also a cascade-based concept, right? And then we have various visualizations and projects related to those visualizations from AIDSview. So if you're unfamiliar with all these different projects, I highly recommend you take a free moment on a break just to Google them. Lots of really cool information and great stuff there about the background behind Care Continuum, early thinking about how the Care Continuum can be used to drive outcomes and drive service delivery. IAPAC has resources on optimizing outcomes along the Care Continuum. And so there's a huge amount of subject matter out there around this. And there are many different resources too, depending on what interests you and what you're trying to focus on as a part of your Care Continuum activity. So it's not like a stretch to imagine that it has become our primary means of testing the effect of services or care activities on HIV health outcomes. And we've even started talking about the bar before the bars when we think about a continuum, or thinking about the integrated HIV prevention and HIV treatment continuum. When we think about the prevention activities, we can even tag those on to steps that happen before patients are even before us for our treatment. And what we know is that many of us are in multi-service agencies, and a lot of us do provide prevention services. So it does lend itself the opportunity for us to link our programs together. Though today we're going to be talking mostly about the treatment side or the treatment care continuum, because it is the preferred framework for HIV outcomes by our federal partners at HSDA. So because of it becoming their preferred framework, they use it all the time. Another reason why you're probably pretty familiar with it. Since 2015, HRSA has used the Care Continuum as a way to demonstrate how Ryan White is a powerful program, it's an essential program, and it needs to be continued. They've been pulling comparisons of Ryan White Care Continua with other care continua that are really based on all people living with HIV within a jurisdiction, so that you can have that sense, right, of what are the differences between the work that we do in Ryan White versus the field at large. What we control is what's in front of us, right? We know what's happening in our own shop. We touch our patients. We see the outcomes that, we help them to achieve. And it's really great to have this counterpoint or this opportunity to check what we're doing against what's happening in the overall field at large. What we found is that Ryan White tends to have much higher performance and non-Ryan White tends to have much lower performance. HRSA has been able to determine that its funded system is very strong, and it's basically the private healthcare system that's causing low national outcomes. And so there are gaps that are attributable to that difference in outcomes between what all of the wraparound services that we have in Ryan White versus the general healthcare services that the private sector has. And I'm sure that we can think about this, right? Like when we think about the services that we're providing to patients, we touch them in many, many ways with case management and peer services and food and housing and many different types of assessments. But if we think about our own experiences as human beings going to the doctor, when you go to the doctor, for the most part, you don't have all those wraparound services. And I can attest, as a person living with HIV for 20 years who's been part of the private sector, I've never had really a case manager or any of these other wonderful supportive services. And it's been lucky that I've been able to maintain a high level of, health and health outcomes for myself. But, perhaps there would be a benefit to having these other supportive services. So all this to say is that we can reflect on our own lives to think about the network of services, the full suite of services that are offered through Ryan White. And then it starts to make sense that even though we're talking about higher risk, higher need folks, we're providing them with more services and we're providing them with more support, which then leads them to live longer, healthier, happier lives, sometimes, and even those who are in the private sector, which is kind of like an interesting thing, right? Because as Americans, we often think that the private sector will be superior to the public sector. But the care continuum modeling that's been happening for the last 5 years shows otherwise. And so it's an interesting concept how we can get some skin in this game and start to have these comparisons locally. Well, our partners at DSHS have been doing this. And our partners at the Department of State Health Services actually have put together some comparative continua that actually demonstrate what I just said. So the green bars show you the performance for the Texas HIV Care Continuum, and the red bars show you the Ryan White HIV Care Continuum. And what you can see is that the Ryan White Care Continuum accounts for about a third of all of the cases. But when we think about viral suppression, we make up almost half of all the viral suppression in the state. So you can actually see how the care continuum falls. So for the green bars, over time, we wind up falling so that only 61% of people are virally suppressed. But in Ryan White, we have 82% of people virally suppressed. This is impressive. And it's really important for us to keep this in mind, that this is literally our work that's being shown back to us, and literally our life-saving activities saving lives. It's pretty cool. And it's really neat that we have this opportunity to view this at the Texas level, at the state level, to be able to identify and start to think about and pick apart, well, we are able to maintain a higher level of service, and what is it about the services that we provide that allow us to provide that higher level of service? What is it about the way that we interact with our clients that allow us to achieve these higher results? And what is it about our clients and our activities with our providers that make them willing and interested in pursuing activities that help them to lead longer, healthier lives? So when you think about HIV care continua, there are so many definitions, and that goes all the way back to, Ed Gardner's 2011 care continuum, and then the way that Irene Hall graduated it somewhat. And when you think about the way that we parse out the data, there are so many ways that we can make definitions. So one of the ways that we can get around this is through the concept of care markers. And the concept of care markers really is just a sign that care was provided. And care markers can be collected and reported by subrecipient agencies as the description of the care that they provide. And additional care markers managed by the administrative agent supplement the subrecipient reported care markers. So when you are entering your data into ARIES, the AA is able to pull the data out of ARIES to generate their Ryan White continuum, and since the AA is part of the state, the AA can work with the state over time to help to create the care continuum for the system for Ryan White and the care continuum, within the county region overall. And that will require some coordination, right? Because I used the bad word, I used ARIES, as our way to have our system level data. But we need to make sure that we have our system level data in the system in order to be able to have our Ryan White continuum. Our friends with the AA are able to, get all the other information that they need to generate that, that full continuum through EHARs and surveillance. So, again, everyone has a role here in creating this system level, care continuum that compares all cases with Ryan White cases. One of the things that, has been a real strength in Dallas is that you all as subrecipients have had a pretty clear picture of the data that you provide based on your own home health records. And that's been a godsend since folks have had some questions about ARIES over time. But again, it's really important to remember that our system level data suffers when we don't have good data integrity and maintenance processes, or when we have them, but we don't really pay attention to them or enforce them. Right? Like, we really need to make sure that the information that we have in the system for ARIES is to a certain degree so that we're able to intelligently draw conclusions without running the risk of making erroneous assumptions or conclusions based on incomplete data. So care markers are as good as the data that produce them. So here are some examples that come from the state of Virginia, just to kind of give you a sense of how this works. So the state of Virginia started with the CDC definitions, but then revised them to meet their own data expectations and requirements. And that's one of the things that we have available to us too in Dallas region. Of course, we want to stay tied to the state so that we're able to compare ourselves with the state, but that doesn't mean that we need to be 100% precise. Again, a care marker is defined, but the most important thing to remember about a care marker is that it's a sign that care was delivered. So, as far as care markers are concerned there, they use CD4 counts, viral loads, genotypes, or any other type of lab assessment, and that's a great way for them to have a sense of what's happening outside of their own shops. Evidence of care would be one care marker within a 12-month period. Linkage to care would be evidence of care within 30 days of diagnosis. Retention is 2 care markers in a 12-month period, at least 3 months apart. And viral suppression is the last viral load in the 12-month period that is less than 200 copies. So the way that we would make these definitions come to life for us in Dallas is that you've heard about the internal CQM committee and the external CQM committee that the AA now has. The AA will convene these groups to discuss what is the way that will make the most sense for them to define their measures. All right. Yeah, the groups will come to a consensus on the best way to define these measures. And then that happens mostly in ARIES in the background and then comes back out to you. We'll talk about what your special role is on variants later. I know that you're probably thinking about that because we had mentioned at the beginning. We'll come back to that. First, let's just look at the care markers themselves. So what does the state of Virginia do with this information? It's really cool that, again, you can see here how they compare what happens in Ryan White versus what happens for all people. So the all people living with HIV is the taller bar, it's the light blue bar. And we have all persons living, no, all Ryan White is the upper bar, sorry. And all persons living with HIV is the blue dark bar. Sorry, my eyes are crossed. And we can see here that same theme, that same understanding that we've seen in other states and cities across the United States for the last 6 years, where Ryan White performs above the general medical system in Virginia. They're also able to segment their data because one of the great things about having system level data is that you do have client level information, in ARIES that can then, we can rely on to pull information out. So here we have performance by race. And we're looking at Ryan White clients by race and their performance on the care continuum. So this is to give you a sense that we can start to look at disparities as well as a way to tell the story. And you can see here individual continua produced for different racial groups, from linkage to viral suppression for white, Black, Hispanic, and folks of other race. Here we can see another type of demographic segmentation based on gender. And so, you know, I put this here as a way to show you could do age, you can do whatever demographic factors are most important for the patients that you serve. And there are lots of examples beyond demographics as well, right? We have clinical disparities that can happen based on the number of comorbidities, based on active substance use, if we wanted to be super specific. We could look at distance to clinic, like how far a patient has to travel in order to make it into my shop, as another way to look at disparity. There's so many ways that we can look at disparity. And I just wanted to put this up here as a way to show the power of disparity analysis. And here's one by age as well. So you can see that for each of these different disparity groups, what we've done is we've created an individual care continuum to show for a point in time, where is each of these groups? This one I wanted to show as another way to look at care markers and how we can use care markers and the care continuum as a way to drive our decision making. So here now we see 3 points in time for each age group for viral suppression. So we can see how viral suppression adjusted over time, whether we're improving or remaining stagnant. And it looks as though based on these results, I would say that each of these groups is remaining relatively steady. But it's important for us to have the information and for us to be well trained in looking at data and coming up with a statistical understanding of where we are with our various groups and the services we're providing to them. So where do we start here? Where do we start in Dallas if we wanted to do something similar to what I just showed they have in Virginia? Well, let's start simple. We're going to start with just care markers, and we'll enter our encounter data and lab data, and that'll be a role that you have. While it's an expectation that there's 100% complete data entry within ARIES, in terms of the way that we want to build the plane as we fly it and keep on keeping on, we want to focus on just one thing at a time. Remember, the best way to eat an elephant is one bite at a time. So the comparison of results and coaching to help close variance is something that the AA can help with. And we have our friends in the CQM team, and we have other staff at the AA who are very interested in helping to improve the data integrity within ARIES and to make sure that we have strong system level data. We don't know what we don't know, and we know what we know. So, you know, in terms of thinking about what we do know, we know everything about Ryan White clients. And we know the number of newly diagnosed clients that are touched by the EMA and HSDA. Sometimes there's a little bit of delay in that one. But again, this is one of the strengths of having a system like ours, where we have folks that are funded to provide both prevention and treatment services. So more on that in a little bit. But it's really important for us to keep in mind that we can only control what's in front of us. We are interacting with patients, and then we can enter the results of our effort in our home record and then translate that into ARIES. But if we don't have that information available, then we don't know. It's great that we have a lot of this within our own shops, but the system level data and the system approach is really important for us to keep in mind as a region such as Dallas. So with this, I'd like to turn it over to Jamie, who's going to, oh, no, I think I have one more, yes. So let's look at the definitions that we're gonna be going through in the next several slides. So we have the total number of clients touched, and all this data that you're gonna see comes out of ARIES. So the total number of clients that are touched by a service category, the number of new clients touched by the service category that were recently linked to services of that service category, and the total number of clients touched by a service category that were retained for services in that category. And you can see this actually kind of creates the way that this has been done or conceived of in Dallas. We have two continua at once. That first one is really thinking about the clients touched in that category. The second one, in orange and yellow below, is looking at the number of clients touched by the service category that hadn't ordered CD4 or viral load, and then the total number of clients touched by the service category achieving viral suppression. This allows you to look at the services that you're providing at your agency and to understand how that service category is keeping and retaining its patients, which is, if you think about it, if we divorce ourselves from quality for just a moment, that's a pretty cool bottom line type of thing from a business perspective that a lot of agencies and administrators might be interested in. But then two, what is the effect of participation in a service on the care continuum? And there's a lot of really important nuance and context to keep in mind when we dive into that conversation. And we cannot be making, you know, huge sweeping assumptions. And I think Jamie and Thomas will talk a little bit more about that.
Awesome. Thank you, Michael. So what we wanted to do is kind of get into what does this actually look like using those definitions that Michael just went over. And just a friendly reminder, you know, a lot of this information, including those definitions, are included in your toolkit. So sometimes it's really helpful to have that to refer back to. So for this slide, what we wanted to do was just show you an example of the HIV care continuum kind of built out that way. And then in the preceding slides, we're going to go through some specific examples. So just to give everybody the same foundation of understanding as we start to look at the care continua, again, that first bar is going to be the total number of Ryan White clients within a specific service category. And then the second bar is of those in that service category who are also newly diagnosed, were they linked to care within 30 days of diagnosis? And that third bar being of those folks in that service category, how many were retained in care? Then we move over more toward the right side of the care continuum, and we begin to look at folks within a service category who had a lab ordered. And then of those folks with the lab ordered, how many of them are virally suppressed according to our definitions? So what we've tried to do is build out this care continuum for everybody so we can start to look at what is each service category's relationship to the care continuum and what does our overall system level data tell us. Just keep in mind, we do provide the percentages and then also as a point of reference, the number of clients within each bar as well. So let me see if I can advance to the next slide. Michael, I might need some assistance. Thanks. Alrighty, so here's our first example, and this is actually the overall EMA HSDA 2019 Care Continuum. Again, our data source is ARIES. So we see the total number of clients served by the EMA HSDA is almost 11,000. That first bar is always going to be 100% because that's really just sort of the group that you're starting with. For our newly diagnosed, linkage to care is nearly 65% within 30 days of diagnosis. And out of everyone served in the EMA HSDA, we have around 31% retained in care. When we look at folks with a lab ordered, that's 73%. And of those who had that, 60% are virally suppressed. We can advance to the next slide.
So I don't know, Jamie, also if Thomas has any contacts that he'd like to add as well. I'm sorry that I forgot to prompt that before.
Okay, we can share the love. It's all good.
No, I don't have anything to add. I just want to make sure everybody knows that the reason that the link to care looks smaller than the rest is because your denominator is a lot smaller. That's only the clients that have had a first HIV positive within that reporting period.
Thanks, Thomas.
Jamie, we have a question from Kat. He's asking if an agency doesn't have access to medical records / testing, how are you supposed to know which of our clients are virally suppressed for that sort of report, especially given that information regarding their status can be inaccurate or missing entirely in ARIES? Maybe, Thomas, would you want to elaborate on that?
I'm not exactly sure. That's something we may have to work on, because agencies that do not provide a medical service, historically, we tell them, please do not enter any type of labs that the clients may bring with them. So that's something we may have to work on in the future to find out how we can get this information to those agencies that do not provide an outpatient ambulatory health service.
But can they have access to general info of the client via ARIES?
If they go into each client individually, they can definitely see the medical screen, but that would be more of that'd be arduous, especially on an agency like CATS that sees so many clients.
So Thomas, if the client shares an ARIES, should a subrecipient who provides support services be able to see labs if they are in ARIES from another OAHS provider?
Right, but they'd have to go through it client by client.
So these are important questions for us to tackle when we when we move forward with this. And in terms of thinking about the how we share information for our clients and all of that, I think that those are important considerations. And these were raised already as kind of anticipating some of your questions from the field. The AA is already, looking into some of these concerns, and for our next internal committee, which will be in a couple of days, I wouldn't be surprised if some of these concerns are raised then. So keep the feedback coming. This is really important.
May I jump in real quick? This is Julie from Texas DCHHS Quality Coordinator. And so the viral suppression and CD4 counts are a requirement by RSR. So all of the agencies should be entering this, and we run reports, and when there's missing data, we follow up with the data manager. So this data specifically should be in ARIES. Like, there are some things that we know aren't as complete as other areas, but this particular data, I believe, is very accurate. And so if you share, you should be able to identify or see these lab results. There are different kinds of reports where you can run and then cross-match them, so you don't have to do it one by one. But we can definitely get you more directions on how to do this and share that with you. Does anyone have any specific questions for me? I don't want to interrupt the presentation, but it definitely can be done. Thanks.
Okay, awesome. Yeah, so thank you guys. We'll keep monitoring the chat, and then we do have an opportunity for breakouts and different discussions to kind of talk about variance in data and what's needed, how the AA can be supportive of subrecipients, and kind of come up maybe with some solution tools. And this is just part of a larger commitment, I think, to broach this topic and just kind of keep moving forward so that we can have the best system level information and be really data informed in a way that we're all collectively confident in. So we can advance to the next slide. Sorry, I don't think I have that ability to do that independently, Michael.
It's okay. Are you on slide 21?
Oh, I'm so sorry. I need to go to slide 20. My bad.
Sorry.
Perfect. Okay. No worries. I didn't realize. All right. So what we've done is we've looked at the overall care continua, and what we've begun doing now is breaking it down into specific service category. So here we have 2019 APA, the care continua here. And again, we see that there were around almost 2,400 clients accessing that Ryan White service category. And then of those clients accessing that service category, as Thomas said, the denominator for the next bar are going to be newly diagnosed clients within that measurement period. So of those folks, around 74% linked to care within 30 days of diagnosis. And then also 42% of folks accessing the APA funded service category show retention in care. When we begin to look at folks within this service category, a little over 93% had a lab ordered, and then of those folks, around 80% showing viral load suppression. We can advance to the next slide. And here we begin to look at outpatient ambulatory. And I think Michael spoke a little bit earlier, it's really important to begin to not only have a lot of confidence in your system level HIV care continua, but how do you do segmentation? So segmentation by HRSA funded service category is, a really good starting place and one option. So here we have outpatient ambulatory, around 7,200 clients accessing that service. Nearly 70% of the newly diagnosed folks within outpatient ambulatory health being linked to care, and around 41% retained in care. For folks within outpatient ambulatory services, ARIES is reporting almost 92% with a lab ordered, and of those folks, nearly 76% virally suppressed. And here we can begin to compare these health outcomes, not only across the different services, but we can compare one particular funded service like outpatient ambulatory to the overall EMA HSDA. Next slide, please. Here we have our medical case management. Again, each bar letting you know how many clients access that funded service, and then what percentage of those clients are linked to care, retained in care, received one care service, meaning that they had a CD4 viral load lab ordered, and then viral load suppression. Let's compare medical case management to the next slide, non-medical case management. So we have a larger portion of clients accessing non-medical case management, and we can begin to look at linkage to care within 30 days of diagnosis at 64%, retention in care a little above 37%, 81.33 having a service, meaning a viral load or CD4 lab ordered, and then of those folks, nearly 67% with viral load suppression. We've got one more funded service specific care continuum we can advance to here. We have oral health. So once again, we've broken down sort of the care continuum in two stages, showing you how many clients access each service as a point of reference, and then the different care markers and health outcomes within that service category. What I want to do is actually advance to the next slide and talk about really important care marker considerations. And I think we see that, working in Ryan White, especially at a Part A office, I think there's a natural tendency to consider services that seem to really directly impact the care continua, like outpatient ambulatory, and then start to think about some of those wraparound support services like housing, food, legal, or others that seem to maybe more indirectly impact the HIV care continuum. So some really important care marker considerations would be to ask, how do services included within every funded service category play into the HIV care continuum? How direct or indirect is that relationship? For agencies that are funded for multiple services, how are you interacting? What do those care partnerships look like? And regardless of what service individuals are accessing, these care partnerships are critical, regardless of how immediately we see ourselves. One of the things that Michael mentioned earlier in the presentation was also, the bar before the bars. And so when we think of the HIV care continua, there's also a lot of social determinants of health, housing, food, trauma, violence, economic mobility. There's a lot of influencers that have an indirect effect on an individual's engagement in care, access to care, adherence. So I think it's really important for us to always keep that in mind while maybe we don't see those social determinants always directly, kind of popping up on our charts and our graphs. And I think finally, another consideration would be, what are those ways we can triangulate the effect of provided services that, that only indirectly influence the HIV care continuum? Next slide, please. And as Michael mentioned earlier, the integrity and the maintenance of our system level data is hugely important. So, you know, there's kind of that phrase, garbage in, garbage out. And so I'm really excited that we have the AA team and everyone on the presentation today for the first part of performance measurement to talk about how we can just work to have the best system level data. You know, once we get confidence and a shared understanding of where this data comes from, how often it's updated, any potential limitations, etc., that's when you can really start to also look at segmentation. You can take a deeper dive in your data. You can do some disparity analysis, and effective change can really jump off at that point too, which is really exciting to see. And now I think it's time for me to hand it off to folks with the AA.
Great. Regina, are you muted? I think you are. Let me unmute you.
Jen?
Oh, maybe she stepped away for just a moment. All right. Angie, would you mind sharing what the purpose of the 29AA QI project is, or is that something that you feel comfortable doing in Regina's absence?
Yeah, I'll quickly go over that. We were just wanting to go over, we noticed a lot of data variances and from the different sources we have with ARIES and with our state and federal partners, and just the different quarterly reports that we get. What we have in ARIES is different from what people have in their EHRs or their home-based systems. So we did a 2019 QI project on data assessment, and we wanted to try to standardize or try to see what the problems were first, and then try to, as much as possible, get everybody on the same page so we can be comparing apples to apples. So the system level data are always essential for QI and is an ideal driver for planning and evaluation. And it's really hard to plan, or even evaluate if you can't rely on the integrity of your data. So that was one of the things that we've been having a problem with at the AA for a while, and we decided last year that we were going to try to tackle it. The Dallas EMA HSDA has poor system level data quality based on ARIES, and an operational QI project was designed to identify and address its shortcomings. By completing an analysis of data completeness, we'll have a starting point on how to improve our ARIES data, which is our system level data system. So when we all came out to you guys, agencies last year, and we sat and talked with the CQM and the data people about how they grab their data and what they do with it. This was the beginning of our QI project at the AA. And again, the purpose was just to try to identify what some of the issues were and to resolve and move towards resolution, to have consistent data so that we're all looking at the same thing and we can begin to plan and evaluate our processes. And then Oscar will go into more detail.
Sure. Thank you, Angie. This is one of the analyses that we run at the AA, and trigger, in fact, the project of data analysis, because we found very inconsistent and discrepant data in the one that we can collect from ARIES. And let's face it, that's the system that we rely on. We have to rely on it. We have to make it more consistent, more accurate. So this detail came up for the report that you provide to ARIES. Remember, ARIES is not just a billing system. It's the system that we collect the data to measure these markers that make the program effective or make it look so low in productivity on viral load suppression, which is the ultimate goal in the care continuum. Take care of our patients, take care of our clients, take care of our population, and have them virally suppressed. The purpose of early medication, treatment initiation, all initiative actually pitch into the care continuum. We have, for example, big examples there on agency level data that we have on ARIES at 68% of viral suppression. Then we run different, deeper analysis with Thomas and be more specific on that, actually came up with a lower number. But then what the report that you provide to us in a quarterly basis, the source that you use create, for example, 81% of viral suppression. This is the same agency, same timeline, and same data. But what we had in return, it's very discrepant data that we create this project. And the main idea of the project was, like Angie mentioned, to determine why it's so discrepant. It shouldn't be discrepant. Numbers are very clear, very strong. And yeah, it has some acceptance of variation of some difference, some percentage of tolerance, but not that big. That margin of error, it passed 30% average, so that's way too much. So I mean, we create this tool and we want to see the data cycle to determine and diagnose basically where's the missing link. So we went over that some of you created data manually, some of you created data basically merged into the system, or some of you created in both ways. The XML file is a manual moving pieces of the puzzle, and it translates who knows how. Problem is, the data on ARIES, we haven't provide back to you and tell you, okay, this is your report. That's Karen was mentioning, like, okay, this is something like, it's too low, exactly, because the numbers on ARIES showed that one. So we went over, and behind these tables, you'll have basically the fishbone analysis, what we found. Michael, do you mind to bring that behind? The fishbone analysis gave us point gaps and actually good results as well, because we determined that system is not the problem. Internet, equipment is up to date in every single agency, okay? Access to that ARIES to EMR was one of the links that really was kind of missing. And we didn't have the way to create that, like, in our reach. This is our findings after going into your agency. I'm pretty sure you remember we were talking about this. Equipment and system, the equipment is great. Problem with the system is the EMR doesn't interact with ARIES. There is multiple platforms, data collection, and the distrust on ARIES, because it seems like historically once or twice almost collapse and crash. The methodology is one of the things that we need to fix and need to determine, okay, what dictionary we're going to be using. What will be the denominator? Well, will be the numerator, okay, the amount of clients, but what about the exclusions? Some of the systems create exclusions, some of them they don't, or the exclusions are different. So the material, the guide of performance measures are different from each agency. County and state and local, HRSA level, state and county are different. And another big one that we had is there is no verbiage on the contract about CQM. Now it is. Right, we create that one, a very comprehensive list, a bullet point that think that you will actually need to be involved to know more about CQM, to get engaged more in CQM, and make CQM and ARIES as our data reporting system more reliable. And we need your help. Yes, that help will go back to you in the sense of knowing where you are. And I'm pretty sure you know where you are based on your EMR, but HRSA doesn't know where you are because ARIES is blocked, incomplete, or is not really communicating quite well with us. Like Kat was saying on the text, okay, how are we gonna find out those patients who go to a different medical provider? Yes, that would be an extra effort from the randomized provider who determined those viral loads, those CD4s, those medical visits, because that system, it's very difficult to integrate into ARIES because it's private sector. So we rely on ARIES, and we'll encourage you to rely on ARIES and make ARIES more accountable. I think in the whole process of this data analysis, this is in a most summarized way that I can explain. Thanks. So go back to Angela and Angie or Regina if she's back.
Okay, so we're talking about the next steps now for our project that was done at the AA for last year for 2019. So new in 2020, we have more detailed CQM contract language with expectations included on ARIES data entry. Starting with care markers aligned to the HIV Care Continuum, we'll work to address our system-level data integrity. Subrecipients will be asked to complete an activity and follow up to this webinar today. Later in our series, we'll be announcing our EMA HSDA 2020 QI project that will be focused on engagement in HIV care. So our collective actions today will make for a healthier tomorrow for our region's people living with HIV. So we didn't forget, what we were doing last year. It took a minute because of everything that was going on. So we want to give you guys, some feedback on all the happenings from the data assessment that we did last year. And we're going to be talking about what we're going to do with what we found.
Great. So, we're in like the midpoint of our presentation today, and we just wanted to take a moment to pause. There's some great conversation happening in the chat room. Just to kind of pull out a couple of things that I've observed, it sounds as though there's interest from the subrecipient field in having a roundtable or some type of conversation to help drive the design of this new system, which is awesome, because that actually hits on several of those points that were just made in that fishbone diagram that Oscar was showing. Also, another thing that is really neat, based on what we had already said, was that we're starting small and simple. We're going to create common rules and a common understanding from a place of 1 or 2 measures that are aligned with the care continuum, and we will expand from there. So we're eating the elephant one bite at a time. In terms of thinking about how all of this works, we still have the internal CQM committee and the external CQM committee, and this work group basically would just help to supplement them and to help guide their work. I'm sure that they'll appreciate that, so it's less on their shoulders. I don't know if anyone else has any reflections or anything they'd like to share based on what they saw in the chat room, or it is an open conversation, so please unmute and share if you have anything else that you'd like to say as well, folks.
Come on, guys, you're not shy. We know that.
Thomas, what are you thinking about, the conversation that we're having so far and, our ability to do this? It's not going to be easy to make change, but, does it seem like this is something that will be practical, like we can do one step at a time, or do you have any other thoughts or words of wisdom to share?
I was just going to add something. Starting last year, I had come up with a procedure. Every quarter, I had the 3 agencies who import medical data, remind them on a quarterly basis to make sure they get that data to me. And they've actually been very faithful getting that data to me. Some of them very quickly. The other 2 agencies who provide outpatient ambulatory care, they actually do theirs manually, and their numbers look really well. So the data recently has been a lot more accurate than it has in the prior years.
That's so important. That's really important context, because it tells us that we're actually already heading in the direction we need to go, and the lift may not be as heavy as folks, might be worried. I see Kat's note in the chat room that, contrary to popular belief, it is hard to enter data and time consuming. And I don't think that, it's, folks would disagree with you. But I think the important thing is finding these practical first and next steps that we can take so that, we remember our quality mantras, right? Yes, there are contractual obligations and expectations, but we need to be kind to ourselves, and we'll do what we can do when we can do it. And so this is the system voice all together saying that these are the things that we're going to do as we can do it, like one step at a time. And we're going to work really hard to make sure that folks are, not left behind as a part of this conversation.
Michael, this is Karen. Can you hear me?
Yeah, hi, Karen.
Hi. So I just want to put in the, the universe that there's been a lot of changes that have happened in the EMA, starting with the RFP to some service changes in billings to billing backup documentation, a lot of extra. So there is a sensitivity around administrative burden, and I'm just putting that because it's a little bit of a context going on out here for providers. I don't think anybody is at all not supportive of wanting more detailed ways to slice our data, take a look at how we're performing, and be aware where we have disparities, because that's the only way we're going to be doing the effective programming we need to do. But I do think it's super important that, and I appreciate your comment back, that the voice of the provider is brought in relative to feasibility and exploring how can some of these things move forward with least impact on administrative burden for the agencies, because it really has increased. And, you know, you hit a line of demarcation where you're going to run up against little resistance because of that potentially. So just be aware that that's there. And I don't think it's anything we can't get through, but I really do appreciate a willingness to sit down on a broader level than perhaps just this group. For instance, if I had really understood what we were talking about today, I probably would have included Nicole, our data manager, and probably some clinic people, because I'm not the one data entering and managing all that. You know, a lot of different moving pieces go to make the agency work. And I would want to hear their input on how this shifts. The other thing is exploring if we can build data bridges, because we're all centralizing a lot of data in EMRs, and we're doing a good job with that. We use that to look at disparities among our patient population with viral loads and so forth. But now if we have to turn around and re-enter other information, I'm not talking about what Julie said was basic, but you know, we just have to be mindful. And if it starts to grow as we talk about this project over time, that might be an area for consideration of additional funds. Historically, we've been told if you need equipment, ask for it in your budget, but that would mean cutting services to do so. And so I just am putting all those themes out there to put kind of on the radar screen as we all kind of move forward.
I really value that. And I see some other folks in the chat room in the community who are also valuing that contribution. You know, I'm reminded in quality, we also oftentimes say how much juice for the squeeze, right? You know, and you know, there comes a point where you can't get blood from a stone. So it's really important for us to keep all of these things in mind. You know, one of my former bosses, Bruce Agans, always used to say, like, I'm a public health practitioner, but damn it, if public health doesn't run amok and make a mess. You know, and that's exactly what you're talking about, Karen, the idea that, you know, we have good intentions, but we can bring the world to its knees if we're not careful, you know? And so having all of the hearts and minds and hands at the table together to determine what is going to end up working for most, and hopefully all, you know, over time is going to be really important. And so thank you very much for raising that and for making sure that it stays on the top of our desk. Any other thoughts, questions, concerns? I see Norma's question in the chat room. Will we receive training on the appropriate manner to query data from ARIES? And yes, in terms of thinking about the way that this works for your own internal variance checking and all of that, like we will be creating little toolkits and packages to go out for folks with that. Just so that in case, you know, again, to Karen's point, like it's always hard to get all the right people on the line, you know, at all the same time. So we want to make sure that you don't have to attend the webinar or else you've missed out. You know, we want to make sure that, you know, the webinar is recorded and all that, and that's great. But like making sure that there's like kind of bite-sized tools available in the field for people to actually use, you know, will be really important. And so we'll be working with the AA and also, you know, with various parts of the AA to hopefully put tools like that together. I see maybe something in writing like a policy and procedure. Yeah, I mean, these are the types of things too that from the subrecipient perspective, if there is language or a template or anything that is helpful for you to be able to implement in the field, I'm sure that that's something that the AA would be, you know, interested in helping you put your minds together around that. Because it, you know, it does represent change, and, you know, you can't ignore one set of changes, you know, when you're trying to do the next set of changes. So I think that it's important with all of the change in the dust in the air that we do things like the help with the templates. So I see a question from David. I don't know, Thomas, if this is a question that you can answer, or if there's any thought or sense from others in the field about this. But on the topic of bandwidth, has there been any data or record of how much additional resource and time it's taken from subrecipients to collect and input their data? David's noticed that the top 3 are the big subrecipients, and how does this reflect with small entities?
I really don't have an answer to that. I have no idea, because ARIES has been around since 2005, and you know, it's the same thing that had to be put in back then is the same stuff that has to be put in now.
Yeah. So
I mean, there's been a few things that have changed, but not much.
Yeah. David, are you talking about some of the other administrative data, like beyond ARIES, and kind of like how ARIES and performance measurement fits in with the whole? You type in, you can unmute yourself too. And Kat, per your question in the chat room, we'll get to that in just a moment in the next section. Exactly. Go ahead, David.
Can you hear me now?
Yes, sir.
Okay, perfect. So yeah, just going back to the whole, you know, I think the general main point of the conversation is just quality of information that's being put in, you know, good information in, good information out, so to speak. And so, but like you mentioned, you know, with any great endeavor, there requires sacrifice and there requires resources and whatnot. And so I'm just wondering that, you know, as we're going through trying to get as much good data in as possible, what are those concessions? What are those factors? And do we have data to support that information, so to speak? You know, and so I noticed that just with the PowerPoint presentation that the analysis was with some of the bigger subrecipients, but just don't know how that will be reflected upon the smaller ones.
Great question. I think that, you know, the CQM team started with viral suppression and started with the OAHS providers because they wanted to start somewhere. But I don't know, Angie and Oscar, if there's any additional context that you want to provide, and if there was, if this was just kind of like a pilot to help us get into this year and to think about data variance overall, or if you wanted to do, if we were going to do something as formal with the smaller organizations.
Well, you will have 2 approaches in one, like you were mentioning about building this plane while we were flying it, but it has big component from ARIES. Okay, how much data can be shared via ARIES and how much data can be accessed by that small agency, they call it small agency. I don't like the term that small agency. I mean, every agency is important as it is, but how connected can be, or how much access they can have from the ARIES data, so they can contribute or they can be connected to the frequency medical visit, to the viral load suppression number itself and the date, that kind of thing. So it's going to be like collaboration from both ends, and we have the full intention and the support for from the state to see how much we can get or how much we can connect on those pieces at the provider level and ARIES. So our project can be attached to that, and based on the accessibility and reliability of the data that they can have access to. I don't know if that answers your question, David.
Just to add too, when we did the data assessment and we started with for the QI project for last year, we went to all of the subrecipient agencies. So whatever service categories they were funded for during that time, we talked to them about that, and we did an assessment on all that. And I don't think all of that was included, just the outpatient ambulatory ones were shown, but we do have everybody's data and the name of their database that they're using to get the source for their data. We have all that stuff. And I don't know, Michael, if you wanted to touch on, or you wanted to hold that about the experience evaluation piece, or we talked about some of the support service categories, if we're not able to link them directly back to viral suppression, what some other things that we may be able to do.
Yeah, I think we should move on because I think that we're starting to, you know, steal our own thunder. But like, I think that that's exactly right. That like we have something that is the right shape and size for all of you. Okay, let's see. Let's go ahead and move on because we'll have a chance to revisit the chat room after this next section and before we go into the breakouts. Does that sound good?
Yes.
Right.
All right, Jamie, take it away. Awesome.
So because between, you know, today's presentation and the next presentation, you know, we are kind of dividing our examination of CQM performance measurement into quantitative and qualitative components. So as we're kind of going through today, let's just take a moment to make sure we cover all our bases when it comes to quantitative measurements, principles that kind of go back to PCN 1502, the policy clarification notice 1502. So perfect. So this is exactly what's in PCN 1502. So just as a reminder for Ryan White funded service categories where there's more than 50% of all EMA supported utilization, that's where we're going to have 2 performance measures. For service categories, and this is like collectively across the service category, not just like your agency in that service category, right? So if it's housing, it's all housing. If it's dental, it's all dental. If it's health insurance, it's all health insurance. So if that's 15% to 50%, that's where HRSA expects 1 performance measure. And for funded service categories where there's fewer than 15%, receiving at least 1 service, there's no requirement per PCN 1502. Next slide. So what have we done? So we've put together the 2019 utilization, and this kind of shows for each funded service category, the number of clients EMA-wide accessing that service, and then what is the breakdown of that percentage so that we can start to figure out, okay, what service categories are gonna be above 50%, and we're going to be looking for 2 measures. What service categories fall between 15 and 50, so we're looking at 1, and then if applicable, what is fewer than 15%, where per PCN 1502 there's no performance measurement from that quantitative aspect of performance measurement. And I think now I'm going to hand it off to Michael.
Great. So in terms of thinking about what this means then, let's just go ahead and look at the service categories that we have CQM required performance measures for. So we have 2 for outpatient, we have 1 for APA, 1 for non-medical, 1 for medical case management, 1 for medical transportation, and 1 for outreach services. So it's really important that we take note that there are some of these service categories that lend themselves really nicely to the care continuum, and some of them are much less direct in terms of their effect on the care continuum. Clearly, the reason why we're providing these services is that we understand that they support the care that is being provided to the patient overall. But in terms of making that direct link, we've already had some of these conversations, right? You know, and we saw in the chat room people, you know, saying, well, wait a minute, how are you going to be judging my program based on the care continuum when I have such a distal effect, when I'm so far away from the care continuum outcomes with the services that I'm providing in the day-to-day? And so, you know, what we'll do now is talk a little bit about how we can make that happen. So, you know, just quick knowledge check. Do any of the services provided at your agency have any required CQM performance measures? So thinking back to that last table, there's only 2 agencies that don't. Are any of their required measures care markers? So what we're going to be doing is coming up with a list for these, where we're identifying which of these service categories are going to be aligned with care markers, and which of them will be aligned with something else. So that's where we start getting into the qualitative piece, and when we're able to start thinking more about how the services that we provide are indirectly tied to the care continuum. We have built that right into the conversation. And so to the question that was in the chat room, you know, what are we going to do for these service categories? Well, we're going to assess the effect of the care continuum qualitatively as opposed to quantitatively. So basically what you would do next for the care marker piece is, you know, once the care markers are defined and you have your supportive resources, we would want you to submit your care marker data for only those service categories that have required CQM performance measures directly to CQM staff once a quarter. And then they'll take that information, that's very limited information that you've provided to them on an Excel sheet or whatever template we provide, and they will do the comparison on the back end to compare the data that you submitted with what's in ARIES with Thomas. And that way, everyone is still doing all of their 100% contractually obligated data entry into ARIES, but there's only a little tiny bit of extra work that's required for you to do this data validation piece. And this data validation piece is going to be the way that, one, we make sure that we have strong system level data for the care markers as we roll them out, one bite at a time. And two, that we've allowed for different service categories to be able to be analyzed in different ways. So like for those service categories that don't have a care marker, we're going to ask you once a quarter to submit your survey information. And so we'll be talking a lot about surveys and focus groups and how we create those measures next time. And just like the care markers, there will be a system level conversation that occurs where the system determines for all subrecipients providing a certain service that, you know, you can ask whatever questions you want in your survey, but you need to include at least this one, you know, and that would be the information that you submit on the quarterly basis. So then from the policy clarification notice and our federal partners' expectations, we will be submitting, collecting, championing information as required that meets minimum expectations. We also will be driving forward massive system change and improvement based on the way that all the different service categories that we're measuring and looking at in detail are playing together in the sandbox. So this is just, you know, a reminder that what we're doing all together here is we're building the plane while we're flying it. And we all have a piece. You know, the AA has a piece, you have a piece in the field. And I think I like this one because everyone's kind of looking at everyone else for the most part and trying to understand, you know, what pieces each other has. There's the guy who can't take it anymore and is drinking. And I think that this is a pretty fair depiction of where we're at right now. We're all trying to do our best. You know, as has already been mentioned from some of you, that in the field, you're all trying to do your best. And there's an acknowledgement of that. And so we'll all build this plane as we're flying it and do great work together. So I just wanted to take a moment before we break into the breakout session. If, you know, the little segment that, that Jamie and I just provided answered the questions that were in the chat room. I think that Kat had some questions and some other folks, and I just wanted to take a moment to make sure that we answered those questions, or if there's any other ongoing questions that we should tackle.
I think that's an observation from Dale on collecting new data points is more difficult. Just a quick answer, that data is being collected already. It's just the matter to organize that and have the accessibility via ARIES. But you are collecting the data. And now that you're providing outpatient ambulatory health services, that'll be actually like melting perfect for you and bringing that data into that as a part of the commonality. And Norma asked, can one performance measure cover more than one service category? I'll say, yeah, you can cover non-medical and medical with the same indicator of, let's say, viral suppression or medical visit. So those two questions are like the most recent one. Yeah.
Yeah, I think that I would add that if you did have, let's say that we selected viral suppression for both outpatient ambulatory health services and medical case management, then you would have to submit viral suppression separately for those clients. That's the one thing that's really important, because this is a service category level determination. It's not an agency level determination. So it's a little wonky the way that all this plays out and the way that our federal partners have designed this, but I think that we can do it. And we've got, as long as we keep in mind that we need to be judicious, we need to be practical, we need to eat the elephant one bite at a time. Yeah.
In case of Nova, they have access to all the data because they have the clinical service plus the support services as well. So they have the connection how to get that information.
Great.
Just
Right,
Michael, real quickly too,
please.
when you, I think it maybe was on Jamie's slide when we first started talking about the PCN 1502 and the requirement or the number of performance measure per percentage for service utilization. That's for the whole EMA, right? Not for each agency to develop their own based on their utilization, because we're unclear about that when they first came out, and we never really got clear guidance from HRSA on that. So can you just kind of restate that just in case somebody's unclear still?
Oh my goodness, thank you so much. Yeah, and hopefully this will alleviate a lot of heartburn and gas for you all. This is only for the recipient level. The recipient determines, you know, what measures based on their recipient level information. So, you know, the EMA HSD as a whole has data that determines the number of measures. So each agency doesn't need to do its own calculus in terms of, you know, what percentage of its clients receive a certain measure, unless it's a Part D, a Part C or D direct funded entity. And then our federal partners would expect that, you know, you would have performance measures that, you know, for your recipient agency that meet the expectations of PCN 1502. But again, thinking about the way that the system fits together, we do have direct Part C and direct Part D funded entities. And you are part of the system and network. So the system as a whole for the EMA and HSDA wants to play ball with you and wants to make sure that just because you have to do one thing for HRSA, you know, you don't have to stand on your head and do 4 backflips, you know, for the EMA and HSDA. That we should expect collegially that we're coming together, you know, in the center somewhere. So we're not going to let the tail wag the dog, so to speak, because the county needs to run the show for the entire EMA and HSDA for the entire system. But there is definitely and absolutely an opportunity to substantively weigh in and to share your perspective about how whatever planned process is going to end up being, is going to end up affecting your work. All right. So we've had some folks coming in and coming out. I've done my best. If you've seen my stink think face, it's because I've been trying to make the breakouts work in the background. So we probably are all, you know, assigned to the right group, but if not, just we'll roll with it, and we'll use the the breakouts as they're set up. There's around 12 to 15 people in each breakout room. So it should lend itself to a great conversation. And we have 25 minutes for the discussion. So I'm gonna go ahead and do my magic and suck people into those rooms. And I'm sorry, Regina, for taking your slide.
No, that's okay, Michael. And that's quite all right. And then I was going to ask, do we have a mechanism in place to support the individuals that called in versus that will be able to participate? Oh, okay, great.
Yes.
Okay.
For those of you who called in and we don't know your phone numbers or what agency, we randomly assigned you to a breakout room. So you might hear a space on the phone as you're sucked into the other room. But yeah, you should be able to access the room just fine. You can also,
Question too, Michael.
Oh, go ahead, please.
I'm sorry, quick question. Someone asked too, if they're on the phone, can they participate in polls any kind of way? Or not?
That's the one thing that's a downside. Yeah, we don't, as far as I know, there's no way to participate in the Zoom polls when you dial in. But the breakout rooms are still here, so we still have that. Sound good?
Sounds good, thank you.
All right, friends, here we go.
So I tried to get into the breakout room and I couldn't get in. Oh, now I see it. I'm sorry.
No worries, Carla. Okay, so let me stop share here so that we can see each other. Hi, everybody.
Well,
hello, hello. All right. Well, I'm really glad that we have, friends from AIDS Healthcare Foundation, Parkland, Cali Clinic, and HSNT in today's breakout. And so we tried to stir the pots. So we have some of the same folks in our room today, but some different folks too. So the first question that we have for the breakout is, in what ways do the services you provide at your agency lend themselves to the HIV care continuum? And that's an easy one for us because we tended to be a lot of the hospitals and clinics again. But I wanted to kind of like encourage you to be expansive in your thinking, especially for the supportive services that you provide. And especially since many of you are in one-stop shops. You know, have you considered the way that the services you provide lend themselves to the care continuum, and what have you found? We have a shy group today. I'm gonna have to pull some teeth.
Sorry, I just got my computer audio working.
Oh, no worries. Hi, Piper.
Hi.
Would anyone like to share how the services they provide at their agencies lend themselves to the care continuum?
I would venture to say that ours are relatively clear stated, but I'm interested to see how this evolves with the EMA's efforts to break into those medical case management, non-medical case management, transportation. Those are the care markers that I think would be very supportive, and the other support ASOs could get really behind as we shift. Because when we had this conversation, what, 5 or so years ago, and determined the definitions, everyone's kind of felt the strain of, it doesn't really measure what we're doing as an agency. It's a nice beginning, but I think this is a good time. I'm looking forward to seeing how we adjust the care markers within all of the service categories that are more supportive, because we have to start somewhere, I think, and how seeing we can give it a shot. And I think if we lag and spend all of our time talking about how ARIES doesn't work, then we will never get to a better point in time. And so we got to try something. So I'm here for the trying something team.
Thanks for that. You know, is there anything, any particular concerns or, you know, things to keep in mind when we think about some of those supportive services and how they link in from your perspective at Parkland, or just in general based on your experience as an expert in the field?
I think our two biggest issues, they're probably 15, but two of the biggest issues are how we've used ARIES in the past as a billing unit. And billing is so patient decentralized, right? That's not very patient centered. Billing is a matter of keeping record of how our funding is being spent and allotted across the board. And I would love to see a shift where we're able to identify the patients receiving the services from each category and then report thusly. So just making sure while we're building the care markers and sharing with agencies, being very mindful that we're all aware of these are for billed clients, or these are for, you know, we really delineate those nuances, just really qualifying the data to where everyone, like we've said, feels more comfortable knowing that we're all looking at the same piece, and we stop saying, oh, that's not right, that's not right. Because we know our internal databases will most likely be off some way. And while we work to align the internal data pieces that we see, we'll know that for this service category, for this purpose, we're looking at this set of clients that we'll be able to delineate and mark and see, right? Because that's who, like, we want to see who we're serving to where we can really make an impact. If we just are a portion of a billing or a percentage that's backdated retroactively, it just takes the patient and the care out of it. And I'm sure that's what frustrates the smaller, which aren't small, the supportive ASOs, because everyone's doing work. And if they're entering it in at the last minute, you know, like, who part two of this is if the agencies are entering, like we're not entering functionally in ARIES live, like as we're delivering the care, we've switched to our electronic medical record, and then we have the capacity to pull out. But that doesn't mean that the information won't be pulled out accurately, or that it'll be pulled out inaccurately. If we can direct it the right way, I will say internally our data team is great, and I think anyone with some guidance can make their exports feasible to where they can pull from whatever source that they're using. Most data sources or databases have an export potential, and as long as we're communicating about how and who to export, then we will find ourselves with better, stronger data.
Yeah. You know, we have Thomas in our group, which is pretty rad.
Yeah.
Thomas, I don't know if you have any reactions to what Piper was just sharing, or if we're just kind of listening as we go.
No, it just goes back to what I said earlier, that the data in ARIES is actually better now. It's the problem of getting it out, because all of us know that ARIES does not run the HAB measures correctly. Of course, we're kind of not looking at HAB measures now. We're looking at these care markers that are a little different, but it's still not as easy to get the data out and put it into a form that gives us information back. I think, you know, us as a group at Dallas County are going to have to sit down and figure out how we're going to come up with how we get the information to the agencies, and come up with a way to train them on how to get it out and put it in a form that makes sense.
I think that speaks to like the request for templates and all of that. I think, you know, folks in the field are showing that they're like, hey, I'll roll with you, you know, just help me out, show me which direction and all of that. So I feel like, you know, what we're trying to do in these conversations is to break into pieces. You know, if we're going to have, there's an elephant, needs to be eaten. We need to like start cutting it up and looking at what bite we're going to be taking when. And so that's really what we're trying to do here. And, you know, it's not going to be, I know that we're painting a pretty rosy picture right now. And I think that you're all pretty realistic and practical, that it's not going to be 100% easy and all roses, that we're going to end up needing to, you know, keep going back and talking and, you know, reassessing and making small tweaks. And by having templates together that we're all looking at the same issue and, you know, dissecting it the same way, then we'll, you know, really be serving ourselves with that. So I don't know if anyone else wants to contribute, you know, what ways their services that they provide lend themselves to the care continuum or don't, before we move to the next question. All right. So this is a good one. You know, we've heard already what some supports would be, but what supports can the county and state provide your agency to be successful in using the care continuum to drive a conversation on how services provided at your agency, you know, can be improved. So this is thinking about tools and resources for ARIES, tools and resources for the conversation, tools and resources for, I don't know, what do you think? What types of tools and resources will help your subrecipient agency to have the data for the conversation that will drive planning and improvement?
This is Brian, and just something that we've talked about, Julie and I, you know, the project that's going on to identify data discrepancies between what the monitoring and what's in ARIES. And so when we get that data and can look at it and really understand what's going on, one of the things that we used in another program, and we've talked about it, which might be a resource, is to then provide a hard copy data sheet that has exactly what you have to put in to the field for people who really, because you've got turnover and a lot of people who are the data entry people. I mean, these are the lowest, usually lowest paid people. And so there's turnover. So one of the ideas was, what if you came up with a sheet that said exactly what you need to put in, especially on the clinical side, and thinking from the perspective of somebody doesn't know anything. And so you have the document, and then you have like tips like, okay, that you need X, Y, and Z. And so I used that in another program, and it really turned things over on the quality of the data, because then we didn't go through the process we're going out. We didn't identify where the problems were. We just did it for everything, which probably is more work than we should have done, but we did have that. And we did see the data quality improve, because then the users knew exactly what to put in. And then the other level that we added, and I'm not saying we do it for us, but then the users actually, because it was a new data system, it's called Medit. And so they could contact somebody on the team if they had questions. And that's because we built the system ourselves. You know, for ARIES, and HRR, it's a different animal, but that's just, you know, something that we found helped get things, the data got better. So some sort of thing like that might be something to look forward to. I'm just throwing it out there.
I see that Piper put her hands up for that one. I don't know. I don't know what others think about this type of template. You know, sorry for my space. I wanted to make sure that I was able to reassign Aaron, but you know, what other types of tools and resources, or in terms of thinking about the template that Brian mentioned, are there any things that you would like or need to see on such a template in order for the template to be successful?
This feels like it's like it to be determined. Like I don't even know how quite to weigh in on what would be needed. Maybe if we'd already seen the care point discussions, like where we could all kind of start to digest where these care points are coming from, we could know if it's a survey that has to be built with, you know, inclusive data points to be expected, that would drive some certain questions. Or if we knew, you know, we're going to look at medical visits by, you know, this delineation, context helps. And so stay tuned. We'll probably have, we're normally not quiet, but it's, I think having to kind of process, it's exciting seeing the county and it's the state coming together and really driving the process that's so necessary. It'll be necessary for the clients that aren't being touched, and it's important for the agencies that are doing the work also. You know, like, it's just good to have that bi-directional communication. So that for me is the best step. And then the rest is I'm just staying tuned. I don't know if anyone has any immediate concerns. We're differently positioned than other agencies, I'm sure, with export and having team, you know, a team that's dedicated to it. So I'll be quiet.
Yeah, I am surprised by the quiet, but I was wondering also if that was what was going on, like in terms of this is, you know, a different way to have this conversation. I know that this conversation is exhausting when you've had it in the past, and you feel as though it hasn't gone anywhere, and yet we're trying to do new things with you. And I think that, you know, that is one of the things that I've always been impressed with the work that Texas does as well, Piper. And in this case, you know, like the way that the new internal committee for Dallas was set up with a stakeholder from the state sits on that, you know, is so important, because then it helps to make sure that the way that the state operates, you know, includes the county's like considerations for the way that it works, you know, in the field. So yeah, definitely. Julie.
Also like to just offer to step out if our presence makes you all feel uncomfortable or that you can't speak openly. But I promise you there will be no retaliation. I also have ARIES drama and issues myself. So I'm with you on the issues that go around data across the state. And I'm sorry I had to leave. It came up at the last minute before I already registered for this meeting. But I really would love to hear you guys talk about like linking support services to these care markers. Like, for example, if you're not hungry, you're more likely, if you provide food bank, right? So if you're not hungry, you're more likely to be on time for your doctor's appointment, which in turn, then you'll be taking your medication, which in turn, you will become virally suppressed. So to see the pathway, how all of these support services link to improved outcomes in your health, right? So I'm sure you guys talked about that while I was away though, but if there's any need for us to explain that deeper, let us know.
Ooh. I will say that I think one of the biggest gaps across the EMA is that kind of seeing the client move across surfaces. And of course, the reporting expectation of completed referrals, right? Closing that referral loop is everyone like hides their head, bangs their head. You know, patient self-report can only go so far. It's very individual. And so any place that even that is a huge care marker of like, they got to care. And then we can say, oh, look, someone submitted a referral, the person showed up, and any kind of aggregate potential there would be tremendously progressive with where we're currently at, because the states where that does work really well, it's because they mandate a care entry data system, period. Lumps, bumps, all of it together. Where we have more individual autonomy for whatever that's worth, and it has huge value, it comes back to haunt us when we're talking about where do we really close the gap. And that's what's needed. So any place where we can have these awkward conversations of, you have to enter this, period. And then from there, you can do everything you want to outside of this. We build templates that way. You can add and customize and move around your template in your progress note however you wish. It must include these pieces. That guidance and that continuity could help get some of us past the crying and denial part, and then get back into where we could see a benefit of that information being provided. Okay.
So that's exactly our plan, Piper. So hopefully we're able to complete it, but we're collecting this baseline data. And then we're actually going to reevaluate our policies and decide, is this really, do we need this data? Why are we asking them to put this? Is in fact anyone putting it in? Like, do we need it? You know, what do we need it for? All those types of things. And then we're going to try to make meaningful, common sense initiatives on our policies. Let's remove this one. Let's strengthen this one, that kind of stuff, and then provide technical assistance to the AAs and then to the subrecipients, or along with the AAs to the subrecipients, so that we can get feedback and information. So we're not asking you guys to do things that don't really have any value, and limiting the things that we are asking you to the things that are most valuable, and respecting everyone's time so that we get the outcomes of the data that we need, or the not the health outcomes, but the data completeness outcomes, if you will.
And also kind of related to that is also look at processes. So for example, with one of my AAs, we're looking, you know, the MOU process that the subrecipients send in to the AA about, you know, who they have. And so the other thing is to look at the contract and make sure that let's say an oncologist is sending you know, everybody who does a referral, doctor always sends the referring physician a letter about, hey, thank you for the referral, blah, 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 I did X, Y, and Z, and kind of looking at some requirement in the MOU so that that document gets back to the primary care provider who manages the client, so that they know what happened. And, you know, obviously it would either go into ARIES or EMR, because it really puts the primary care provider at risk. Because if that patient, let's say, for example, has a low-grade cervical dysplasia, I know you guys have clinics, and they end up with high grade, and then you never hear from them again, that provider is really put in a bad scenario. And I can't tell you how many, it's statewide. So that may be something as a fix that we look at from a policy standpoint, where we say that if we're going to pay for a referral, you have to make sure that the outcome letter gets to the primary care provider, wherever you want to do it, and then either they upload it into ARIES, which would then make it, or HRAR that you could check to see was there. So like if the monitor was there and they check to make sure, okay, the outcome was there, or your EMR. I don't know, but that's details that have to be worked out. But that's another example of processes that we're looking at, because it just, and so when you go to that subrecipient, say, well, the state says you have to send this. We're paying you. We're paying for it.
Yeah. I love this. I hear 4 things really that are coming out in terms of supports that we need. And it kind of fits into the idea of the toolkit box again. The toolkit box for CQM performance measurement in the EMA and HSDA should include instructions, templates, trainings, and then opportunities for longitudinal discussion. And it's really wonderful that we have the external quality committee and we have the internal quality committee. But what I'm getting the sense is that there's an interest, or a desire, or a need even, for the subrecipient field to be pretty deeply involved in this conversation, and whether or not there are ongoing quarterly conversations forever, that's one thing. But we should have some type of discussion group where people can come together to share their findings on the services they provide, what it means in the field, what's easy administratively, what's really, really the hard nut to crack, and I love this idea of, Piper's point of, the, like a recapture blitz, or kind of like, the list that you can ignore because they're confirmed in care somewhere else, or this type of issue. These interventions would come out of those discussions, on a rolling basis, based on what you find and as you do it. Those are the things that really stand out to me in terms of some of these resources. Is there anything else before we go on to our last question? We have 5 minutes left. Okay. Let me see if I was supposed to do that in the breakout groups? Anyway. All right, so the last question is, what next steps can you take in the process to reconcile your home record system data and ARIES data? And I haven't heard from most of the folks on the line. Have you done any steps to reconcile your data? It sounds like some folks have, and this has caused some gas and some problems. So if there have been challenges, if you've done this type of variance check and then it hasn't gone anywhere, I'd love to hear some of the barriers or challenges why in the last 5 minutes of our breakout.
Kim, are you willing to share your experience with the data that we had over the End Disparities Project? Even though there was discrepancy? Thanks.
Yes. When I started on the End Disparities project, I realized there was an issue with our viral loads being updated in ARIES. Part of that was new case managers at one site. One site had new case managers, the other one had case managers that had been here a while, and they were able to keep up with it. Once we got them trained properly, we actually got our data up to date. Unfortunately, we now have 3 new care managers. So I'm working with getting them, I guess, in a workflow where they're getting everything in a timely manner. I had just pulled my report for last month before this meeting, and we have, let's see, I only have 8 that do not have their report in, which that's really good. That's a lot better than what it used to be. But we do have some where, okay, their tests are old. We need to, it's not that they haven't had their test, it just hasn't been uploaded. And then we also have some that need to be closed out. So it's getting them in the correct workflow to where they're doing all this in a timely manner.
Thanks so much, Kim. I remember another thing that came up during the End Disparities is that you identified by checking your EMR versus ARIES reports, that you were pulling in a lot of clients that were actually from other agencies, right? Because they hadn't closed them out in ARIES, and there was an issue with the sharing thing. So these are the exact kind of things that can help others, because they might be experiencing the same, what's going on here? Why are these clients showing up on my list? So those are the kind of trainings we want to provide to the subrecipients once we identify those commonly happening issues. So thank you for sharing, Karen.
Yeah, Piper's down with that too. It looks like, you know, I think that, you know, again, thinking about the different supports and resources that can be provided, it sounds like, you know, having opportunities to consider some of these other issues as well, like case closure, like when is a patient out of care, like how you run these, you know, turnover is real. It's a real pain in the butt, because as soon as you have all of your chicks in the nest, all of a sudden some are leaving. So then you have to start over, you know, and so having I guess like concise training materials that are packaged by someone else. And then, you know, as an agency, you're able to say, like, you know, it's kind of like when you're a teacher, right? Like teachers take a textbook and they don't say, read the entire 500-page textbook. They say, read chapter 2, read chapter 5. What the city and the county and the state are seeking to do is to provide you with the resources that you can then curate for your staff appropriately and as needed. So I think that there are a couple of great ideas that have come out of this. I'm going to end the breakout session, but is there anything else, any other thoughts that folks want to share? No? It was a much more quiet group this time, but I'm hopeful that we're getting stuff out of the conversation, and that it's causing you to think about, you know, the different considerations that you'd like to raise in future meetings. And as this system comes online, you know, the call is out to participate and to be meaningfully involved in the design of the system that you're a part of. So we really, really hope that you'll take us up on that invitation and will join us at the table as we make moves together. Yay. I can't believe how quickly these 2 hours go by. All right, we'll be sucked away in just a moment. Or actually, it's the other way around. We stayed in the main room. Welcome back, everybody. Hello, hello.
Hey.
Hello, Michael.
We talk about that. We need a full day.
Right.
Discuss the topic. There's a lot of things to bring out. But it's a very, very good feedback. I mean, couldn't get to the last two questions, but the first two kept us entertained very much. A little summary on that.
Well, that's great. We have a couple of minutes left. Maybe if Julie, Angie, and Regina can each summarize in less than a minute, kind of like what some of the discussion points were, that would be really great. And I can summarize too, Julie, if you'd like.
I'm sure. So our group was really very quiet. We talked about issues with ARIES, of course, and how to identify them, maybe using a template so we all are doing the same thing the same way. Let's see, what else? Shoot, I'm trying to blank. Michael, go for it.
Yeah, no, it sounds as though folks are really interested in a number of different supportive resources from the state and the county. And basically we would be creating toolkits, you know, and we could create a toolkit for CQM performance measurement in the EMA and HSDA. That would include things like instructions, templates, you know, canned trainings, and that like each of these different resources would point to, you know, policy and procedure or processes or flows. You know, basically the state and the county could curate resources that are available for you to use as needed in training your staff. And really importantly, an ongoing discussion group where we can raise issues that are pertinent to our performance measurement, especially as we get started, seem like really important ways to maintain engagement with all of you, the subrecipients in the field. So that was group one. Yeah, it was a quiet group. Angie, go ahead.
I think for question one, all the recipients, subrecipients were pretty aware of how the services that they offer impact the care continuum and the end game of viral suppression. So we were pretty expressive and everybody participated in that one. Some of the things that we talked about for the second question, are you wanting all the questions or any question or just?
Go right ahead, yeah.
Okay. Some of the things we talked about for how the state and the county could assist really was about some of the data issues and how some kind of bridge or some system to get their homegrown system to import, upload, talk to ARIES so that they're not having to try to, double, triple, quadruple enter data and information. And so you can be able to pull the information out pretty easily. And then, let's see. Some of the, also just a lot of changes and the things that have been happening at the AA has caused a lot of instability in the field for the subrecipients and over the past couple of years. And everybody's kind of, going with it, doing the best they can, but it is kind of stressful for all of, everyone. And they're hopeful that it will lead to, better outcomes for everybody and we'll be able to streamline processes and workflow, and it will be stable soon so that everybody knows, what is expected of them and is a shorter process. And then we just barely got time for the last question, but just kind of really making sure that there's room in ARIES for the performance measures that are service category specific.
Fabulous. Thank you so much. And since I see that we're at the top of the hour, Regina, any can you summarize in just a sentence? Sorry.
No problem. So I guess what stood out for me was they're saying ARIES is that the data is being shared, but not being shared. And that sums it up pretty much.
Great.
I'm sorry. That was a question. That was an issue in ours too. Somebody just reminded me, just the whole ARIES sharing problem.
Mm-hmm. Yeah.
We're really happy to have our state partners at the table with us, for this conversation. And I know that Julie and Brian will take some of the thinking, and conversation back to the team, and we'll continue to discuss and to evolve together as a community of learning, as a community providers in the EMA and HSDA.
Yeah. Michael, may I say something too? It was also a concern, just quickly, that individuals weren't able to have their data personnel on the on board on the call on this training. If everyone would pay attention, usually in the description of the curriculum, they will say who the audience should be. So please pay attention to that so we'll know who to invite to the next trainings. Thank you.
Thank you so much for that. Thank you so much for that, Regina. Jamie, why don't you walk us through the action planning form that, basically at a high level that we have as a part of the poster?
The data variance. The data variance sheet? Yeah. So in your toolkit, we have, I was calling it the data variance. Apologies. We have some questions that we're wanting folks to look at the form, after today's presentation and sort of go through and ask yourself those. I think there's 4 questions. Sorry, I didn't have it.
No, it's okay.
Hold up. But essentially to walk yourself through that, to put some thought, because kind of identifying those challenges will also help set up some action steps for what we can do, how we can take bites of that elephant, one piece at a time. And then that will also help lay a really nice, strong groundwork for information as part of your poster and your final sort of project throughout this training series.
Yeah, thanks, Jamie. So just like with the other worksheet for CQM plan and committee, if you have any questions or concerns about it, or if it doesn't seem, if it doesn't seem right to you, just pick up the phone and call any of us. You know, Jamie and I are available, and the CQM team is definitely available as well to help you work through any questions you have. And as a reminder, these will, you know, be on the final project, the poster at the end of the series. So we had wanted to have a moment to talk about the Texas Viral Suppression Project as a way to show how in real life, in real, you know, time, we're using the Care Continuum to drive a quality project in Texas. But I don't think we have the time since we are running late. So we can look forward to an update on this in the future, and probably when we're announcing our retention and care project that we're going to be doing for you know, our region, then we can talk about this project as well and how these two processes complement each other. So my apologies, Julie and Brian, I'm sorry that we have run out of time. Also, I'm going to just pass this for just a moment, Regina, so that we can take care of our poll and our evaluation.
Right. And the question for the polling, there's two questions in the polling. The next step being, as of you are clear, thinking we have a clear understanding what we're going to request from you or what you need to provide to us to into the data into the CQM in the service, and the confidence level of ARIES. It's a very interesting question. We need to pitch into that. That's our source of information.
All right, we have 14 of 32 votes. Let's see if we can get into the mid-20s this time. We're at 18.
And there, 18.
All right, great.
All right,
so let's share the results.
21 out of 31. So thanks a lot for your input. 29% of you are clear what to do next. That's great. That's great news because we all need to pitch in. And somewhat clear, 71% of you are somehow clear on what's next, right? Good news for that because we're gonna keep the guidance. So please don't stop coming to this training and you will have that idea, partial idea to the full idea at the end of this series training. And about your agency in relate to ARIES, it depends on what service we're talking about, 43%. And that actually says a lot because you shouldn't be that pick and choose. 33% say no confidence, like a third of our participants had no confidence on ARIES, and 24% they do have confidence that ARIES can work. So I think that we all need to go back to ARIES because I mean, that's what we have. That's what we count on. That's what the HRSA actually provide and the state provide that data for us. So we need to be very consistent on that and see where are the gaps and how we can fix them up and straight up to make them reliable.
Great. Thanks, thanks, Oscar. Angie, can you walk us through the upcoming sessions we have to look forward to?
Yeah, our next session is going to be on performance measurement, dealing with experience evaluation, and then we have the QI principles and methodologies, followed by a QI project and the CQM program monitoring evaluation, and then our poster symposium. So just a reminder, in the next session, we'll be covering qualitative measurement and experience evaluation. So if you didn't see your agency and services reflected in today's conversation, we'll be covering them in the next time. So be there, be square.
That's right. All right. And we have our final evaluation poll. If you guys could just stick around for one more minute to answer this. And Oscar, I don't know if there's any final words that you want to share with folks for today.
Yeah, one detail that Karen was mentioning on the chat, the synchronization of the support from the AA into the services, it's not quite functioning. That's something that we're going to bring that to the internal CQM committee, which they are part of it. Sonia Hughes and all the heads of the departments are part of that. So we're going to bring that into the conversation in our internal CQM committee, just for you to know, so they be aware of that and how we can fix that. So you will have a services with guidelines at the same time. Not that you have the service, but you don't have the guidance. That needs to be synchronized.
We really do use these evaluations to help us plan for our next meetings. As you saw, we had reduced the number of breakouts and tried to arrange the schedule a little bit for the way that the call went based on your feedback last time. So please, please, please fill out the poll. We have 15 of 31 who have replied so far. Great, and as promised, the last question on this one is about the cadence that we have. We're doing 2 hours every 2 weeks, and just wanted to check in if folks wanted, if this is great and keep it going, or if we need to, take a break because it's a little breakneck, the pace. So we have 18 of 30 of you who have voted. I'll just leave it open for another moment to see if we can capture a few more thoughts before we close.
Someone's saying their submit button is not working.
Yeah, they'll say like something on the end, polling. I'm gonna submit.
Yeah,
Yeah, the submit is not working.
Yeah, mine neither. I can't submit.
yeah, I've clicked on any number of times, so like 5 or 6.
Guys, you have to scroll down and answer all 5 questions. And you can hit submit.
Thank you.
Thanks,
I did.
Thank you for catching that up.
I have all 5 answers and I can't submit.
Huh. All right. Well, I'm not gonna hold up. Based, but I will look into that because I'm really sorry, Marilyn, that you had that experience. We want to make sure that, and Del as well. We want to make sure that all of your votes are counted. So if you have any feedback that you weren't able to share and you want you want us to hear it, you can share it with me anonymously. I won't tell whose thoughts came from where. But in terms of, where we're at, it looks as though we are, still meeting your expectations for the discussion, which is good. It looks like most people thought we were just right, a little bit too long, a little bit too short, but mostly just right. The opportunities to share, were just right. And the content provided was mostly just right. It also looks as though folks are interested in continuing on every other week. And basically that'll take us until early October. So thank you so much for joining us. I don't know, Oscar, if there's any final words that you want to share.
Well, yeah, on behalf of the AA, Sonia, you just typed something like, thank for all coming on. I want to reinforce that message on. We really appreciate your time, and we're looking forward to have you in our next meeting on the 17th and bring the people that you think that will match better. And again, thanks so much, and thanks for the Haggard team to actually are riding and flying this plane.
Amen.
And I would add too, for those who weren't able to attend today, somebody mentioned earlier, they can access the toolkit, the video when it's ready, right, Michael and Jamie?
That's right. That's right. The YouTube channel is up. We are posting those usually same day. So if you need a link to the YouTube channel, you should be able to access it if you open the slides from the toolkit I sent you earlier, the link is right there. But you can also just drop a line and I'll be happy to send you a direct link as well. Share, share, share. Sharing is caring.
Thank
Right.
you.
Bye, everyone. Have a great day.
Discussion. Bye, guys.
Bye. Thank you.